Good morning. I'm Professor Laurie Dillon. I am the department chair for Austin Community College in Austin, Texas. It's a pleasure to be here with y'all today.
Hi, and I'm Laurie Lucas, and I'm the assistant department chair at one of our campuses in Austin, Texas. And we are so thankful to be here. First, we want to thank OADN for giving us the opportunity. We're so excited to have a platform to talk about our proven, innovative model that bridges nursing education to workforce-ready ADN graduates. We call it the Advanced Clinical Immersion Program, ACI. And it's fundamentally reimagining how we can graduate associate degree nurses and get them ready for the workforce. So thank you very much.
So I'm going to discuss the objectives with you. So we're going to translate the vision of an apprenticeship clinical. So we're going to give you the nuances that we used to create the program that we currently have. We're going to explore the construction and execution of the Advanced Clinical Immersion program, and a lot of times we call it ACI, so just be prepared for that abbreviation. And then we're going to share the knowledge we've gained from the inception to formalizing the ACI model. And that really was quite an incredible transformation. So let's get going and have a great conversation. Thank you so much.
All right. The purpose, Laurie, explain the purpose of the apprenticeships.
Oh, I'm happy to. The purpose of our apprenticeships is we are working to increase the experiential learning afforded to all RN students. And so we wanted to really create better connections between theory and practice to allow our clinical students a shorter transition time as they go out into the world as registered nurses. This allows our students to earn college credit while learning to become an RN and finally provide these students with an income. And with that income comes insurance and all the other things that students need to be successful, both as a student and as an employee. This opportunity is only available to those students in the last semesters of their studies under a strict criteria that we have created for our program.
That is exactly right. The Advanced Clinical Immersion, or ACI, like Dr. Dillon said, is a framework designed to give final semester nursing students authentic transition to practice. Each student must complete 120 hours. That's what we've told the Board of Nursing that we're in the level 4 students that they're responsible for. And what that looks like is they literally match their schedule with a chosen preceptor, a vetted preceptor, and they do 10 12-hour shifts independently with that preceptor. However, it's not completely independent. They have a supervising professor that's assigned to them. So both the professor and the preceptor formulate an evaluation for the student. But the student nurse is absolutely accountable and responsible for their practice. And we found that it works really well. The preceptor oversight provides the direct day-to-day oversight. And then the supervising professor comes along as a liaison for the hospital, a role model for the preceptor, checks in on the preceptor to make sure that we are using evidence-based practice. All right, let me see here. So it really is a bridge. Laurie, can you explain how ACI meets the academic hours while completing the TBON hourly obligations?
Absolutely. ACI students are required to be in class on their assigned days. They must meet the criteria of our program with a higher level of rigor. We hold them to a standard that's going to ensure that they are successful. And we're going to ensure that they meet their obligations for class, simulation, and clinical. Meeting our minimum standards for exams and while meeting a higher level of rigor for their precepted clinical experiences really has made this a well-rounded program. The Texas Board of Nursing sets the standards for this type of program at a 24-to-1 ratio. That's 24 students to 1 faculty member, with the requirement of evaluating the students every 2 weeks, we felt that that requirement did not meet the rigor of our programs or the needs of our programs. So we maintain 8-to-1 ratio with every student in our program meeting with their assigned faculty member weekly during their assigned precepted shift. They are assessed by both the preceptor and the faculty on their performance. The Texas BON requires a total of 500 hours for every student who attends our program. Level 4 is required to have 192 hours, but our total program hours at the end of this will be 704 hours. And then, of course, approximately 50 to 60% of that will be simulation.
That's great. Laurie, can we talk about that a little bit? Because I think the decision to exceed the minimum required supervision hours was really the key to our success. I feel like from student reports and then from professor reports that saying that we'll meet with you, we have touch points weekly, and even more so, given the freedom to allow them to even do more oversight with the student has really been beneficial. And I think it's helped us bridge into the hospital better and let our presence be more known as that we are partnering with the hospital. We're not just turning our students over to you to teach. We're actually still partnering. So I think that was a really good decision that leadership made. All right. So now let's look and see how ACI meets the workforce readiness needs.
Well, ACC has ensured the Texas Board of Nursing that we will guarantee our level 4 students have 192 hours at the end of the semester. Within the ACI model, they get 120 hours that are completed directly with the student's assigned preceptor at the bedside, allowing for authentic, hands-on clinical immersion. Then the remaining 72 hours are completed with the student's cohort level, which includes orientation, simulations, and structured learning activities that reinforce critical thinking, clinical judgment, and the readiness for independent practice. This balance ensures both individualized clinical experience and collective skill development. And on top of that, they get the socialization with other nurses ahead of time. They are engaged fully in the entire process. And we take the responsibility of every preceptor very seriously. And so we have tools in place to support all of this.
I agree with you wholeheartedly. Just like you talked about professional socialization. This results in graduates who are really ready to participate in the hospital in a meaningful way. We created ACI to solve this gap, and I think it's really working. I would like to share a comment about professional socialization from an current ACI student. This is what they say. My clinical experience was very positive because of the exceptional mentorship provided by my preceptor, JC. She created a supportive and encouraging learning environment that allowed me to grow both professionally and personally. JC was patient, approachable, and always willing to teach qualities that made me feel confident and motivated. Through her guidance, I was able to strengthen important clinical skills such as charting, administering medications, spiking IV bags. I remember when that was the biggest deal, was learning how to spike an IV bag. So that makes me happy that they included that. And other essential tasks. Her positive attitude and dedication to student learning made this experience truly rewarding, and I'm very grateful for the opportunity to have learned from her. So I think the professional socialization and the workforce readiness is really working in our program. Let's talk about our solution. How do we meet that need?
Right. Well, the reality is that in the final semester, in clinicals, as they were originally designed, limit the real world experience that students can have. Their access to most experiences are limited to what their faculty has the ability to do within caring for 6 to 8 students. In other words, students spend a lot of time waiting on the availability of the professor to perform skills or give medications. They're not allowed to do this with the floor nurse. That's outside of the scope of practice for what was designed. This results in graduates who are academically strong, but they lack confidence and the professional socialization required for today's complex healthcare settings. We created ACI to solve this gap and meet the demand for competent, resilient nurses. Looking at our solution on the next slide will share a lot. Laurie?
Yeah, the ACI program is our response. It's the full immersion experience by allowing nursing students to work with their preceptor and independently go to the hospital. That it has been a full immersion. They really do work alongside the preceptor every day, getting that real world experience. They're paired directly with experienced hospital trained nurses. And I found that we have found that this one-on-one preceptorship is designed to be highly realistic. And I think everybody is talking about that in the industry now, about the realism of the nursing practice now. And so when they get to see real world experience, it really does help them have a better picture. And we'll learn on later on in the presentation, we'll get to hear about the metrics that prove that. So giving them this entire semester to achieve true professional socialization and accelerate their clinical judgment has been very beneficial. Laurie, would you explain how ACI meets the workforce challenges?
Oh, yes, absolutely. By fostering independence and clinical judgment in a safe, supported environment, we are graduating the caliber of nurse that our healthcare systems need. This innovative approach is not only enhancing our student success, but it's providing a crucial solution to the workforce challenges faced by our hospital, one of them being retention. This program builds resilience to be a nurse. And then per Tate states that nurses leaving the profession within the first 2 years of practice is around 33%. 30 to 50% after the first 3 years. More on workforce readiness very shortly.
And to talk about resilience is very very meaningful for us. We've had in our history a student who graduated and they worked 3 months and then could not do nursing anymore. So much so that they left. And so resilience is very important to ACC, and we feel like ACI is meeting that need. Okay, so Dr. Dillon, your groundwork identified the problem clearly. Our students needed immersion, not just observation, to build their confidence and resilience for the challenges they'll face in the nursing profession. I'm going to pause for a minute, Dr. Dillon. I have a question from a guest. I've often heard the term resilience used with workforce readiness. What does that really mean?
The typical graduating student in an ADN program goes into the workforce with just a small idea of what it is to work full-time in a hospital. In Austin, we have 3 major healthcare systems, each offering a solid foundation to start the formal process of a residency program. A residency program is a 1-year training program that all new grads must participate in. At their 1-year point, you have an RN who is ready to go out on their own. So it takes them a year to get to that point, which most do very well, but not all. The average retention rate in a traditional residency, a traditional 1-year residency, is most hospitals between 2 and 5 years lose almost 50% of their students or their residency program. ACI changes that. We create readiness to work as a result of ACI. They spend time in their residency but it's while they're working. They get credit for their residency while they're in clinical and while they're doing all this great work to learn how to be a registered nurse. But then they take the last 6 months of residency they have head on. They are fully prepared for the workforce. Job retention is more than doubled. There's a current ACI student um, supervising professor that demonstrates individual learning. And so these are her comments. I am emailing you to let you know that I have completed my dual credit component of the clinical requirements. I will get my evaluation to you and the remaining homework by this week. Thank you so much for the time you've spent with me. I feel like you on the unit and getting to debrief with you has really helped me understand more about patient care. I've worked hard to develop rationales for giving why I'm giving the care I'm giving, with worked on prioritization, figuring out how to balance it with multiple patients, and how to think about the what comes next. So the ability to forecast and think ahead and see where things go wrong and how to prevent them before they happen. And so we still have a very high statistic here in Central Texas, and I believe this is national, where new grads are more likely to have some kind of error or some kind of misidentification of a patient event. So they have more critical events in their first year. And that's a significant impact on our patient populations. And so they really cherish the time that they spend together with the ACI, the SNI, that has made everyone so successful. And so the student said, "You've made me a better nurse, and in some aspects, even a better person, as I've learned to take feedback, challenge my own thought processes, and pivot when needed. I look forward to finishing this semester with you, and I'm so grateful that you were part of my final semester in nursing school. Truly, from the bottom of my heart, thank you." Those are the moments that make my heart sing as a program director. I could not ask for anything better.
I agree with you, Laurie. I think we could stop here. We're not going to, but we could, because that, I mean, that is meeting the objective. Later on, you're going to talk about what it means to our partners, but that is real words from a real student, and that's fresh. That's this semester. So anyway, I agree with you. It's very moving. So let's see what's next. So Dr. Dillon, you were the visionary behind the clinical model that would build real world resilience in nursing education and therefore nursing. Can you talk a little bit about your inspiration? What inspired you to create the Advanced Clinical Immersion?
Oh, yes, that was actually an amazing process. So, approximately 5 years ago, I was very new to my role as department chair. The Texas Workforce Commission embraced a project that was brought forward by the Department of Labor. The DOL wanted to create more nurses in response to the nursing shortage and the workforce shortage that was across our country. The DOL had the idea that we could create nursing apprentices in a 1 year program, and after the completion of that year, they would be formally trained as RNs and be prepared to enter the workforce. The model they selected was from World War II. It was the model used to create plumbers, journeymen, electricians. Needless to say, that didn't go very far, as every nurse in the room gasped and no, and said no simultaneously, including me. Several of us stayed and listened for the whole conversation, and we began brainstorming when we realized what was possible. Those conversations sparked the idea that could be managed between hospitals and colleges at the local level. The hospitals would be the stakeholders, and the colleges would be their partner. The goal was to create a program where students would get a large number of clinical hours training as an RN while working with the organization as a PCT, a patient care technician. And then all we need was the stakeholder. And so that came when the DOL and Texas Workforce Commission partnered and created grants to allow organizations to create a partnership with colleges um, that would move all of this forward. About a year later, I was asked to participate in a Zoom meeting, and all colleges in Central Texas, and there was a significant number, were asked to participate. And the goal from the hospital who invited us was they wanted to launch an apprenticeship program utilizing grant funds to pay students. Out of the 12 or so colleges that were invited, I was the only one who said yes, and ACI was born.
That's great. I mean, that's the power of hanging with it and then being able to imagine what it was like. And I feel like in nursing, a lot of things are reinvented. This reminds me, the ACI reminds me a lot of the diploma programs where nurses would work right side by side and they would get their nursing diploma, another pathway into nursing. And so it reminds me of that. Also, I just feel like what's igniting across the country, what's true in Texas can be true for other states too, and that's why we're presenting to you today. But also, we've noticed it even in our own health sciences program that many health sciences programs are following our lead and doing apprenticeships. So I think it meets the needs of shortages across the country. So thank you. Um, okay, Dr. Dillon, I feel like I'm peppering you with questions. I'm so sorry. Would you expand on the metrics that explain the impact of ACI with our partners?
These metrics are absolutely amazing. So the immersive nature of the ACI program dramatically increased their professional socialization of our students. They are fully embedded and emerged for 120 hours with their preceptor. The student experiences the true demands of the job, the long shifts, the high stress moments before they are officially hired. This exposure eliminates the common reality shock or imposter syndrome that causes many new nurses to leave their first job. ACI graduates have a higher resilience and have already integrated into the culture of the nursing unit and the organization, leading to significantly better retention rates and lower turnover rates. And that is actively demonstrated by these slides. Clinical partners report stronger retention at 1, 3, and 5 years. And so graduates are workforce ready. And one of the big things for us all the way around, and I'm sure others have experienced this as well, is imposter syndrome. Nursing students who go through the
Yeah.
traditional clinical experience don't think they can really do it when they really can. We've given them the tools. We haven't been able to give them all the confidence they need to proceed, as well as the socialization that is imperative to this whole process. So if you look at our data in the slide here, it will tell you a lot. But one of the things that we really find so impressive is our ACI group has a 98%, is it 98%, Laurie?
Yeah,
NCLEX pass rate.
I know.
And so every student in ACI passes their NCLEX. They go into practice, and then they are 6 months later out of their residency and going being put into charge nurse roles and having other experiences that the typical student does not get to have.
Oh, I know what it is, Dr. Dillon. It's a 100% pass rate, 98% first time pass rate.
Thank
There you
you.
go. All right. So those outcomes really do reflect the power of this structure and the consistency of the process. That's our vision. Okay. Mhm.
And that vision and a few positive outcomes is everything we do to sustain this program. So, Laurie, what are you interested? Excuse me, let me rephrase that. What are the interrelated concepts of operationalizing ACI, and what did that look like? And I think I just messed up. Can
No,
you
you no,
edit?
you did great. No, you were just asking what are the interrelated concepts of operation ACI, and what did it look like across 3 campuses, because we have 3 campuses.
And this is what happens when I stumble. So take it, Laurie.
All right. Okay. You didn't stumble at all. As we expanded ACI, one of our priorities was making sure that we're in full compliance. So there was a rigorous evaluation of what was expected from us from our regulatory environments, or the Texas Board of Nursing, what we tell them we're going to do to have it be a great program, our accreditation board, and we're going to talk about that in a little bit. And then there's Texas workforce policies and education. So when we reviewed that, there are like 13 different entities that speak into nursing programs. And I'm sure you're aware of that too, all across the nation. But so operationalizing this program wasn't just about logistics, it's about accountability at every end. So every operational step had to align with the TBON, our accreditation standards, and workforce education policies. So we built compliance in, because nobody wants to be found in the end not doing what's right. So let's do right every day. And so that was sort of our goal. And so we built compliance into the design, from the preceptor qualifications to the faculty supervision to the way clinical hours are distributed and documented. That structure made ACI sustainable and very regulatorily strong. I made that word up, but that regulatory compliance is paramount. So let's see on the next slide what that entails. All right, first we talked about the Texas Board of Nursing. For us, it's at the top. I'm sure they all go together. They're all very much important. ACI is at the center. So every element from student selection to site evaluation was structured to comply with our Texas Board of Nursing rule, that 2015.10, that talks about oversight. And Dr. Dillon alluded to that earlier in our presentation, that we exceed what they expect. The ACI model was designed to meet those regulations and the requirements for clinical supervision. We do a little bit more than that, and it has served us well. So if you don't hear anything else, I really do feel like going above the minimum requirements really does serve a program well. We also ensured that faculty maintained ultimate responsibility for the learning outcomes. Even if there's a preceptor model, we are such strong liaisons and supervising professors that we make sure that our rigor is being maintained. The clinical hour documentation, the faculty site visits, the preceptor qualifications, all align with our BON Rule 2015.10. Because in the end, we want to ensure safety, right? We have a duty to protect the citizens of Texas. And so we do that by making sure that we're regulatory compliant. So in the end, all preceptors are vetted. Our clinical partners help us with that. There's no way we have the bandwidth to interview preceptors, but we do have a process for that. And it is related, and you'll see when we look at documents later, it's related very strongly or correlated with the supervising professor's role. They have a strong relationship with the professor. So operationalizing ACI meant building a structure that was academically sound, accreditor ready, and easily audible for compliance. So Laurie, would you like to talk a little bit about academic and accreditation regulations?
Absolutely. The program had to meet the internal academic policies of the college, excuse me, while meeting accreditation for ACEN. We aligned ACI learning objectives with course objectives in the curriculum, ensuring that the immersive clinical experience was academically equivalent to the traditional clinicals. Documentation processes and faculty oversight workflows supported ACEN standards on evaluation, assessment, and student support. All course changes were reviewed and approved through ACC's internal curriculum and workforce education committees. Then we had to meet with the coordinating board standards, which is an evolution of change that we created. So we ensured we had everything for clinical compliance covered. And then, of course, as Laurie already described, the Board of Nursing Standards. And so in Texas, we have a coordinating board. Most folks don't have that extra layer. And so the coordinating board is directly linked to Texas government. And so all the rules and laws that come from the state of Texas specifically for our department are all funneled through the coordinating board. It's a very high standard, but we work very hard and strategically to meet every standard.
That's exactly right. So we just went through our accreditation process, and it's always so positive. It's very hard, but it's always so positive. In the end, when you find out all your hard work, Dr. Dillon, all your leadership, all the faculty's hard work has proved to validate our decisions. So can you talk about a little bit about our last evaluation, and what did they think about ACI?
Oh, it was absolutely amazing. And they were highly impressed by our ACI program and the standards and the rigor that we maintained for that program. We had hard data to share with our site visitors, as well as to share the phenomenal work on the preceptor manual and your engagement with me increasing and improving the standards for ACI to develop and grow. So it's not a stagnant body, it's a constant evolution. And so our partnerships agreements were all clearly defined. We worked with the Texas Workforce Commission to identify guidelines and create a partnership in the regulations. And so since ACI was a paid clinical experience, it also had to align with the Texas Workforce Commission and college workforce education guidelines and partnerships, contracts, and learning-based employment and state law. We had to go to the state of Texas and ask them to change the law to allow our students to be paid. We created a memorandum of understanding, MOUs, and affiliation agreements outlining each partner's responsibility, ensuring that the experience met both the educational and workforce training criteria. This ensured that the ACI students satisfied workforce funding parameters and protected the students' rights as learners rather than employees. And we were their toughest critic on that point alone, because we did not want the preceptors or the organization to say, well, we're short staffed today, so and so has to be by themselves. No, that can never happen in our program.
That's right. And we've all been we scrutinize partners. We've not accepted every hospital partner yet if they don't meet our standards. And so I feel like that's a really good thing. Phew, we have talked a lot about the inception, all of the regulatory compliance and how we've planned it. Now let's connect to the student. Let's see how students are selected for the ACI program. There we go. All right. So this is our partnership and clinical selection. So there's eligibility, interview, ranking, placement, and then partner approval. It really is I'm going to say it, the Texas two-step. It's a two-step process. They have to be vetted through ACC, our program, our rigorous evaluation. And then once we get a roster, we send it to our clinical partner. So that's the Texas two-step. Each student is vetted through a structured process. We developed an interview process, and to eliminate any subjectivity, the evaluation process and the interviews are very objective. There are certain questions in the interview that are scored, and we use that score to evaluate to add to our ranking. And along with that, we make sure that their application is complete, that they interviewed well. We do a face-to-face interview, even though it's virtually. I recommend that so highly because we have had students show up not a professional manner, and those students were not moved forward. We've had students show up in pajamas, or just this last semester, I had a student say, "Tell me again what this is for," and they yawned, and I thought, "Oh, not ready yet to be turned over to the hospital bar stuff." So it is very objective when we do put scores to those sorts of things. In the end, we rank them and we move them forward. So it's very structured. It's very transparent. At any time, any of our regulatory people could come in and look and see, and it's very transparent what we're doing. So only qualified students are eligible. Before they can apply to the hospital site, they have to meet our criteria. They must be in the final semester. They must be making progress through the nursing program. They must be in good academic standing and clinical standing from their previous clinicals. They must completed all the prerequisite work. They must attend ACI orientation. They must have a letter of recommendation from a clinical professor. They write a paragraph about why they want to be in this program. They have to go through the interview. They must be professional. They must be good at communicating, and they must demonstrate clinical readiness. So once all of these evaluations are complete, the faculty review the candidates. We redact any names, anything that's identifying. We look strictly at the objective data, and then we select our roster. So it's important to note that they can't apply to the hospital for the hospital's programs until they meet our process. So this ensures that we're giving the best students, the most ready students to the hospitals for their selection. So, Laurie, what has been the response from our hospital partners regarding this process?
You know, we're extremely blessed to have amazing clinical partners. Ascension and HCA have been outstanding partners. They were eager to partner with us, especially because we built in the accountability. But ACC has a reputation for excellence, and that was why they chose to partner with us.
Yeah, I do hear that over and over again. They really do appreciate from you being the first one to say yes, and then creating a space for me to create the accountability and the vetting process. I do hear it over and over again. They really appreciate that we vet our students, and they often say we're the only institution that does that. So I'm really grateful for all of our work. Okay, another question for you, Dr. Dillon. How do the rigors of a clinical course merge into an actual hospital unit? Oh, you know what? I think I can answer that one. It is schedules and oversight. So let's look at that. The student who's at the top in our illustration mirrors the preceptor's schedule for 1 to 2 shifts a week. I have to say, many of you know students in the final semester is the hardest. If they don't do well on their first exam, we bump them down to 1 shift a week. But if they're doing well, they can do 1 to 2 shifts of dual credit a week. The preceptor is the primary day-to-day mentor, teaching them through the immersive practice that we've talked about. The supervising faculty is the ultimate supervisor. They conduct on-site visits, and they pull the student. Ask the preceptor, "Can I borrow your student for an hour?" They take them off the floor for an hour during their supervisory visit. They use Socratic questioning to develop their clinical reasoning. And I think you heard in the students' testimony earlier on that they appreciated so much spending one-on-one time with their professor. The students responsible for seeking their learning opportunities, taking initiative, and abiding by the high standards outlined in our clinical expectations. And
So when thinking about accountability, how do you build in accountability in ACI?
okay, what you're going to see are spreadsheets, but we try to keep them simple. And that's because we have to keep accountability. We have certain standards. So I feel like workflows, workflows that track compliance, make it regulatory ready, right? And that anybody can come in and see. So we developed workflows that track compliance. We've created audit ready documentation. We have oversight for our students, faculty, and preceptor. So to maintain the academic rigor, we do the dual supervision, the preceptor and the professor. This structure ensures academic standards are met while fostering the students' independence. That was the scariest part for us, I think, is the independence, and the autonomy. But with the right supervision and accountability, we feel like it's really working. We've had very few. We've had very few mistakes being made, and I feel like the students that are in our program have performed very well. Importantly, this opportunity is inclusive and merit-based. In other words, they have to meet that criteria that we just talked about, all those interviews, ensuring that only qualified students can participate. So I have another guest question for you, Dr. Dillon. Now that we've talked about student and faculty, how can we turn our impressionable, okay, this is a great question. How can you turn our impressionable students over to a nurse that we may or may not know? Let's look on the next slide and see what we say here. Laurie, I think you're on mute.
So, all right, that's where I usually take a deep breath and it's one foot in front of the other, quite
That's
literally.
yes.
The preceptor serves as a professional mentor and the clinical educator for final semester associate degree nursing students participating in ACC's ACI program. This bridges the role from the transition from student to graduate nurse by providing a structure, real world learning experience in a partnership with hospital clinical sites. So the key responsibilities are clinical supervision and mentorship. They have to guide the student. So we don't just turn them loose and say, here, go. They have to guide the student and support the student in applying the theoretical knowledge to clinical practice while fostering competence, and critical thinking. Then they have to show role modeling. They have to actively demonstrate nursing's professional behaviors, ethical practice, effective communication, and collaboration with the entire healthcare team. They work on skill development, provide opportunities for hands-on learning under supervision, ensuring patient safety and adherence to institutional policies and scope of practice. They provide evaluation and feedback in real time, and their formative feedback on student performance and communicate progress or concerns to the supervising professor or ACI faculty liaison. And so in doing that, we get a much faster turnaround on feedback, which is significant. Working closely with the student supervising professor and the unit leadership to align clinical experiences with course outcomes and organizational goals, and then, of course, the purpose. The preceptor's role is to enhance the student's transition to professional practice by individualized mentorship, exposure to authentic clinical workflows, and reinforcement of the expectations of entry-level nursing practice. So, what tools support accountability with preceptor, supervising professor, and nursing students? What do you think,
Great.
Laurie?
All right, I can't wait to show you this, but this is making my palms sweat a little bit. So listeners, this is where we're going to be real. I want to show you, I have to go outside to my Google Workforce, and I'm going to try to minimize my screen and make it smooth. It may not be, and if not, we'll have handouts for you. But I want to try to share my screen with you. There we go. Let me minimize this. There we go. So Dr. Dillon, are you able to see the faculty supervisory visit expectations checklist?
No, I cannot.
You
What I
cannot see it.
Oh wait,
Yes.
now I see it. I
Okay,
apologize. It just
great.
took an extra second because of my internet.
And there you go. Well, so I know that we talked about spreadsheets, but we try to keep it simple. But I have to tell you, audience, this is so effective because this is what we give this to our professors, and this is the ACI faculty supervisory visit expectations checklist. So every supervisory visit should contain these components. This is such a shift in pedagogy. It just is. And so the first reminder is that the professor is a liaison in the hospital. In other words, we're guests in that hospital. We're not there 12 hours, we're there visiting. And so we have to be kind and respectful to everybody we meet. So they have to say hi to everybody they see. They have to touch base with the unit manager and the charge nurse and the unit educator. As the supervising clinical professor, this is another hat that they wear during this visit. They give the students a heads up of the arrival time. They check the appearance of the student. In other words, are they meeting the very basic, like dress code? Do they have everything? Do they look professional? And what proximity is the student when they first observe to the healthcare team? This has been really important, especially when we do nights, because night shift is a skeleton, as often a skeleton crew. So we always like to see, as a supervising professor, where are they in relation to the healthcare team? So when the supervising professor is doing the inside the visit, they want to see them when they take the student off. They want to see their nurse brain. They want to see their med organizational list, and then they want to get an SBAR report from the student about their patient care. This is the hardest thing for professors to give up, because this is a 10,000-foot view, no longer just a side-by-side view. It's okay if you can observe the student do assessment, if it's possible. The same thing with a med pass. You can observe it, but if it's not during the time you're there, it's okay. You're still getting valuable information by that hour time, asking them about the medications. Why is the patient taking the medication? What are the ramifications of the medication? So they're still doing the 8 rights and 3 safety checks. And it's great if you can observe them do the skills, but it's not mandatory. It's great if, as a professor, you can see them interact with the healthcare team. And one of the questions we often like to ask the students, what's your confidence level right now on a scale of 0 to 10? We've gotten some really good feedback from that. Then the professor asked, do you have the tools that you need to do your job? And then we, of course, use we have clinical foci that we use. And then at the end, the professor spends time mentoring the preceptor. That's how we kind of keep the regulatory loop closed. So that's for the professor. The next slide is just an easy workflow especially for building when we're bringing new professors on, of just what does the workflow look like. So that's just a simple workflow. We also have one for students as well. Like this is what you do preclinical, during your shift, midday, and end day. So those are the workflows that we really spend a lot of time on. And I feel like I know that they look simple, but in the end, we have so much data to show that we are doing what we're saying we're doing as an university or as a college. So, all right. So that's the accountability, Dr. Dillon.
Well, I'd like to add one thing to that, and that is we have a preceptor handbook with all our criteria
Yeah, we
in
do.
that handbook. And that handbook is brilliant. And that's one of the most important tools because we do a formal preceptor orientation. Again, it's not just a here go, it's we explain what this means and how you're going to be involved with us. And we've had a couple incidents where preceptors did not meet the needs of our students. And then we went to the organization and asked for a change, and that was granted really fast. So,
And I didn't pull the preceptor handbook up because I think it's copyrighted, and I didn't know if we were allowed to show that just
we're not.
now. Okay, very good. All right, but it is, and in that preceptor handbook, there's a contract that is a requirement. And so we've got some workarounds on that, how to get it out there. We were having a low return rate. Our return rate is improved now. So, all right, thank you. So that's the checklist and accountability. All right, Dr. Dillon, another question. The ACI is a definite pedagogical shift for clinical professors. What was that process like?
Oh boy. Um, Painful.
Yes,
It
yeah.
really was painful. When this idea was introduced at our first faculty organization committee meeting, um, the level 4 faculty hated it. They were extremely vocal about it. Their hate was visceral, and to the point where they wouldn't even give me an opportunity to really explain, excuse me, anything. And that was an obstacle, to say the least. But it only takes one person to say yes to make a change. And so we got a pilot created. And as a result of that pilot, um, the pilot created buy-in when the first set of data was brought back to those faculty member who previously was so opposed to everything we did. But when we were able to engage them and ask them their feedback, they said what they liked, what they didn't like, and that was huge. And then now going forward to where we are now, they're the content experts for everything we do. They see each student weekly. They take the student off the unit and facilitate the critical thinking clinical judgment component with our Socratic questioning. And they'd rather be directing skills and med passes sometimes, but they look forward to all these opportunities to see the student in the environment they're working and assure that the student is meeting everything. And they are the crucial link upholding ACC's academic standards while collaborating with preceptors to address student needs. The primary goal is to foster the student's professional growth and autonomy when it comes to their decision making. But even though we foster autonomous decision making, the students are never alone until they complete our program. And so that's just one of the things we do to ensure the success that we have. But that was the biggest pedagogical shift in everything that we do.
You're exactly right. I found that as we added more structure, the workflows, structured the supervisory visits, that sort of created the vision. We had to get ahead of the professor to tell him, no, it's a different role, same knowledge, different role. That some of our staunchest critics are now our staunchest advocates.
Why is that? What
Yeah,
happened to win over the expert
yeah.
faculty?
Well, it's a couple things. I feel like the testimonies of the students that we heard today, that's part of it. But in the end, it really is the outcomes. The student reports of increased confidence, the metrics that you've discussed. And so I feel like that's been it. That's the exclamation point on it. So, all right, our next slide is we're opening up for questions and answers. And I have two questions. We're going off script. Okay, are you ready? So,
Okay.
all right, Dr. Dillon, if you had it to do over again, would you do it?
Yes, absolutely, I would. We've made such a difference in student outcomes, and we're getting the organizations who partner with us what they need related to not just students, but competent, confident students. That's a huge shift in paradigm. And if I had my way, every level 4 student would be doing this program. Now, our program is very much set by the students get to choose. And so we'll still have some students who will choose to opt out. But in the not too distant future, I have high hopes that we'll be able to double again because we actually have gone very far, starting with 3 and now we're at 53. But I'd like it to be 180. And so, again, that's a vision that I hope we can grow into.
I'm fully confident that we can. I really do. I feel like that we're on a really good path. And so thank you for your time, Dr. Dillon, and your vision. And listeners, I want to thank you for hanging with us. We want you to know that we're here to support you. So you'll have our contact information. and reach out to us, because that's how much we believe in this program. So anyway, I want to thank you for your time, and please reach out to us if you have questions. All right, thank you. And
Pleasure to see you all.